Good afternoon. Welcome to Medications Affecting the Respiratory System. I've got the categories of different types of respiratory system medications listed here. I'm going to go through and take what is a very long chapter and try to break it down so you need to know what medications you need to know from the chapter. This slide is talking about beta-2 adrenergic agonists. So don't be too overwhelmed by that very long name or category group. Let's talk about the pathophysiology just a bit. In your body, you have beta-1 and beta-2 receptors located in your body. The location for beta-1 is in your heart, and I always say, can you remember that you have one heart? That's where the beta-1 receptors are. Later, we're going to talk about a class of drug called beta blockers for your heart. That'll be later, but right now we're going to talk about beta-2, and you think beta-2, you have two lungs. The receptors for beta-2 are in your lungs. These receptors, if you can activate these beta adrenergic receptors, it will lead to relaxation of smooth muscles in the lungs and dilation and opening of the airway. And the main drug that's on here, there are actually three listed total on the slide. The one I want you to try to remember is the drug albuterol. It also goes by the name Proventil. Please associate those two names together. The medication is a beta-2 agonist. That means that the medication goes in, it helps the beta-2 receptors open up so you can open up an airway. Think about a patient having an asthma attack. Albuterol is available in a handheld inhaler. It can also be given in an aerosol. Because it is a beta agonist, and it goes in and it gets everything it gets your heart to beat faster and your pulse to go up in addition to opening up your airway. If you take someone's pulse and their blood pressure right after they take albuterol, the heart rate will be up. So with the blood pressure, they may have tremors. And the patients need to know this is a rescue inhaler. This is not a maintenance inhaler. That's on another slide. They need to know they shouldn't take this inhaler more than the recommended dose. Depending on your textbook, the one that I have here at home, I am at home doing this voiceover, says 4 to 6 times a day. If a patient tells you they're having to use they feel like they need to use the rescue inhaler more often, we need to find out what's going on with them. If you look on the slides, the things I have talked about here, I have mentioned. There are some contraindications to taking this if you are on a beta blocker medication. A beta blocker medication is used for hypertensive issues. You probably heard, I'm on a beta blocker from a patient. Sometimes if they're having hypertension, we want to block the beta response. So that would be contraindicated. And if you are taking tricyclic antidepressants, the drug Elavil, it will increase the effects of beta-2 agonists. So your education is very important here when someone is on this medication. There are two different medication groups on this slide. I'll start on my left, which is the group called the methylxanthines. And usually when I go and I talk about the methylxanthines, students look at me, they go, I've never heard of that medication. And even people that are already LPNs go, what? I don't know what medication you're talking about. Well, the methylxanthines are old school bronchodilators. It's the only way I know how to describe them to you, being that I've been around a while and some of you haven't seen that medication. When a patient would come in through ER and be admitted in having an asthma flare-up, for many years, when I first got out of nursing school, theophylline and aminophlin were the only two drugs that we could treat the asthma attack with. Theophylline is usually the PO form. Aminophlin comes in an IV drip. It is a very strong medication, and it has a toxic level that you should memorize. The therapeutic level is 10 to 20. In a 10 to 20, if you have to do the toxicity level every day. If the level's over 20, you are just to hold the aminophlin or the theophylline, because this is the old school bronchodilator, so it does the same thing that the beta-2 agonist does. It opens up your airway, and it's very powerful. Patients who drink a lot of caffeine, chocolate, or tea, caffeine, chocolate, and tea are contraindicated on this medication. We can't elevate anybody's heart rate and pulse any more than we already do with the medication. There are two other drugs there. Several drugs in the fluoroquinolone class of antibiotics actually interfere with the metabolism of this drug. This was from the Food Drug Administration. I don't know that it's actually a test question-y type thing, because people sort of ask me all the time. The other thing, they've seen some issues with phenobarbital and phenytoin, which is dilantin. And I always have to talk to students. Sometimes they don't miss the medication question. They miss something very bluntly honest, like to do a lung assessment of the patient before and after you give them a treatment. So kind of keep in mind when you're working with this, the kind of questions, the kind of things that they want you to know. The second medication that I'm going to go over with is on the right, ipratropium. And in case you were wondering about this versus albuterol, so this differs. This is an inhaled drug. It comes in an inhaler. It is sold under the trade name of Atrovent. It will open up the medium and large airways and prevent bronchospasm, but it does not work immediately. If you go and you look at a chart when you take your group of patients in the morning and you go in, you may see that a patient is on both Atrovent, more as a maintenance type setup, and then you'll see that you can give them albuterol if they start to feel short of breath. And Atrovent has some unusual side effects. It has anticholinergic effects. This is where I need you to kind of think back to your pathophys. You actually have a cholinergic system in your body that makes mucus. It makes your eyes wet. So if you take an anticholinergic, it dries you up. Right? So I always remember anticholinergic effects is no C, no P, no spit, and I'm not going to say the last one because I'm a nice nurse instructor, but you can fill it in. So you got to remember, if you're taking Atrovent, sometimes people say they can't pee or they're having trouble urinating. That is a normal effect of a drug that has anticholinergic effects. So you kind of have to educate people about that, and you also still are going to have to let someone know that this is not a rescue inhaler. This is a maintenance inhaler. And patients get those confused. We're going to go on to anti-inflammatory agents. The first one we're going to talk about is the leukotriene modifiers. And the drug montelukast is singular. You probably have heard of that. I found this nice picture here to help out a little bit with your learning about it. A singular is a prophylactic treatment of asthma and seasonal allergies. You have to have very mild allergies to take this medication. And when it says leukotriene modifiers, the leukotrienes are part of the allergic response. If you want to go to your pathophys. Lots of side effects with this medication, but they tend to be ones that are related with allergies: dizziness, headache, upper respiratory infection, fever, cough, a runny nose. If you go down here, you are not supposed to use this medication to treat acute symptoms. You need to use that rapid-acting bronchodilator that we talked about on the first slide. And you have to, if anybody has any type of problems here, this has been known to cause neuropsychiatric events in some patients. I did not know this when I was looking for information to try to improve these slides. There's some people that have one of those lawsuits that you see on the TV about this medication. I should have been really surprised. If you go through your textbook, you'll see that those responses for this medication are very common. People say they feel depressed after they take it. They've also had some liver function issues. You cannot take this drug on warfarin or theophylline. So those are nursing implications for this particular medication. We're going to talk about the anti-inflammatories, glucocorticoids. You also see glucocorticoid is an interchangeable term. And the medication is a medication that I think you all know, but you forget about your pathophysiology. It's prednisone. It also can be given under the name deltazone. Any of these medications all end S-O-N-E. And why do we give an anti-inflammatory? Well, let's think back to your pathophysiology. Your body, your adrenal glands sit on top of your kidneys, and your adrenal cortex makes corticosteroids or glucocorticosteroids, and it helps to control the inflammation in your body. Okay, so if you have a patient, if you think about patients that you can picture in your head or that you may have seen in your lifetime, what kind of patient takes prednisone? Well, let's talk about it. A patient having an asthma attack is having inflammation and may be put on prednisone. People that have rheumatoid arthritis, that is an inflammatory response. This drug is also listed in the arthritis chapter. So when you make this card and you learn this material, you need to learn it and learn it for life. Learn the drug prednisone and memorize everything about it. And it's got more than 5 things you need to know about it. I have had I've had my husband have a gout attack where he was put on a prednisone pack. Anything that's inflammatory. I've seen people with swollen ankles. Maybe they busted an ankle pretty bad. The bone's not broke, but the swelling's very bad. And it's a very unusual medication, and then it comes in a step-down pack. You take you'll take 6 tablets the first day, 5 the second, 4 the next, 3 the next, until you take 1, because we don't want the adrenal glands to get lazy. They're lazy. They're kind of a lazy organ. But this drug has a lot of side effects. It has a really huge section of every chapter I went through for any textbook that you guys have access to. It always has the same issues that go on. And so I'm going to list them here. The first one is hoarseness, and it also can cause adrenal suppression. If you take this medication and you have to teach the patient that he has to take the whole ordered dose on the step-down pack. If anyone wants to see a step-down pack, just go to Google and say, I want to look at a prednisone pack, and they'll show it to you. It comes in a little blister pack. And the other thing, that there's 4 things that can go wrong in your electrolytes when you are on prednisone. And this is the way I learned it. I learned some people get cold. S is for sodium, P is for potassium, G is for glucose, and C is for calcium. So if you look here on this slide, you'll see here the term bone loss. If you are on prednisone, and some people actually don't just take that blister pack for prednisone. Some people take it all the time. Someone who has lupus might take it all the time. And if they take it for a long time, they're at big risk for bone loss and osteoporosis. The second big electrolyte that gets affected when you're on prednisone is hyperglycemia. A diabetic will run a very high blood sugar when he is on prednisone. A non-diabetic will run a high blood sugar when they are on prednisone, and that's something that they expect you to kind of take the lead on. It's something you have to really think about. Someone's going to need extra. They love to ask teaching questions. You know, the diabetic person mentions that he don't know why his blood sugar is so high while he's on the prednisone pack. That's up to you to tell him he may need more insulin, may need to check themselves more. And when I tell you high blood sugar, I am telling you this as a personal one. My diabetic son took one of those prednisone blister packs, and he was getting 700 and 800 on his meter. Because remember, see the word gluco? Your anti-inflammatory in your body is made from glucose. That's what your adrenal gland does. So you have to kind of remember what it does. So if I am on a glucose medication called prednisone, my glucose is going to be up. My body's going to be symptomatic. Okay, you have to think about it. The next thing that comes up is at risk for infection, and anytime you have a higher glucose, you get at risk for yeast. Okay, I always struggle to say candidiasis, but that's yeast. Okay, infection. And the last very important thing on here about this medication is it will eat a hole through your stomach. It will give a peptic ulcer. You can get a bleeding ulcer. You don't want to die from that. So people need to know that they must take this medication with food. Okay, and that is just those complications tie into the nursing implications bullet point below. And I'm going to have a slide. The next 2 slides, I'm going to review these again with you. They're so very, very important. So this particular slide, we're talking about steroids. Interchangeable term would be glucocorticoids or glucosteroids. This is talking about your adrenal glands and your anti-inflammatory process in your body. And you all need to know and you understand that we can give you an anti-inflammatory and the drug prednisone, but it has a lot of side effects that you need to know. So here's some info to help you to remember. All right, if you are on prednisone, you are taking steroids, you may see elevated glucose. Some people see elevated white blood cells, but glucose would be the key one on that first sentence. Right? Number 2, you may see elevated sodium, which would cause more fluid retention. A lot of people say they have insomnia when they're taking this medication. It wasn't like a real big highlight for me from your book, but a lot of people say they gain weight. This is an immunosuppressant when you take it. That means you are at risk for infection. You also may see your potassium go down. And if you take it for a very long time, like most people just take it in this little blister pack, but every now and then you meet someone who's had lupus for 10 years and they've been on prednisone that whole time. Lupus has an inflammatory component to it. And if they've been on it for that long of time, it will lead to osteoporosis. Okay, we just talked about corticosteroids or prednisone. And I need you to really think deep here and pull this out and think critically. There are a large amount of they're prednisone inhalers. Okay, The prednisone inhalers. The first one that comes to mind for me is Advair. My son takes one out here, Brio, and those are not emergency rescue inhalers. Those, because they're anti-inflammatory inhalers, you take them as a maintenance type inhaler. Okay. If you take these particular inhalers, you still have the risk of osteoporosis. There's some people, and they have to teach the patient to gargle and rinse the mouth with water afterwards so they don't get an oral fungal infection in their mouth. They have to understand about the differences between the two inhalers. There's a rescue inhaler and a maintenance inhaler, and they need to take that maintenance inhaler every day as they are taught. I found this great picture at the Allergy and Asthma Network Foundation. There's actually more inhalers available for patients than what is in this picture, but I wanted to keep it simple since you're in an introductory class. But if you look here up on the very left, short-acting beta-2 agonist bronchodilators is on the left. If you go across, it says long-acting beta agonist bronchodilators. You go down here, the one across the middle, inhaled corticosteroid inhalers, and then they actually make these combination ones down here. And I didn't think about this a minute ago when I was talking to you, but Advair is actually considered a one that is a combination one. So if you take a look, these down here have anticholinergic effects. They're breaking it down for patient education, and I thought maybe it might be helpful for you to see it, since I know a lot of us are still virtual with clinical, and I don't have like a drawer to open and kind of show you what these look like. I have a thoughtful question for you. If a client takes albuterol in an inhaler and he also has a steroid inhaler, which should he take first? And I want you to know that and consider that as part of the first question of your learner's guide for future reference. I'm going to talk about antihistamines. There's actually a first generation group of antihistamines. I think most of you have heard of the drug Benadryl. It is just it's been around for many years, and any of these antihistamines, they have Vistaril and another drug called Antivert on here. Antivert is actually for when you're having middle ear problems, but it falls in the antihistamine class. But if you look on here, these drugs are kind of notorious. They will stop your allergic reaction, but they will cause drowsiness, tachycardia. They dry up your nose and your throat. They have anticholinergic properties. They can cause some urinary frequency. They can cause lower blood pressure. They actually use Benadryl now for some of these sleep preparations that you see sold over the counter. The one that I note in my head right now is they have a NyQuil over-the-counter sleep aid, and if you look at the label, it's Benadryl. Before I even talk about this slide, I want you to think about your pathophysiology just a little bit. You have H2 histamine receptors in your stomach and in your nose. There are other places, but I'm trying to keep this simple. The nose is what we're talking about. We're talking about the respiratory system. So that would make, if it's an H2 receptor blocker, that also means what? Antihistamine. Antihistamine. Histamine, H2 being histamine. Okay. This particular Claritin is actually the first generation H2 receptor blocker that came out for allergies and rhinorrhea and sneezing. Zyrtec came later on. Claritin goes by the name loratadine. Zyrtec goes by cetirizine. These two medications will relieve your sneezing, your runny nose, your postnasal drip, the tearing in your eyes, all those things that you get when the spring allergies come, or maybe you have the fall allergies and you're sneezing and chewing. It's very common here in Ohio. A lot of people take Zyrtec. If you think about it, these medications they do have an anticholinergic effect that kind of dry you up a little bit. I feel really dry when I take one. I get a lot of allergy problems. Pharyngitis, you can feel like you're inflamed back in the back of your throat. But they're very, very helpful to shut down the allergic response you're having. I want you to look, if you look over here on the right, I put the term here for you. Histamine blockers are also used in the GI chapter. And if you look at the drugs that we're going to talk about once we get to the GI chapter, they have the same, they're in the same class. Cimetidine, ranitidine, and Pepsin AC is also still sometimes used. Zantec's actually been taken off the market for some problems, but when we get there later, I just want to tell you something that happened. Someone came to me. I was sitting in an office before I came to Bryan and Stratton, and I was just getting ready to head out, and a lady came to the door, and she wasn't young. She said, I heard that you're taking over farm, and she said, I really need your help. I have a test today. I said, all right, let's go over to the library. And I got over there, and she had a worksheet from her instructor, because even though they're asking us not to just pass you through school, but, you know, to do study guides, to give you something to kind of give you a clue, drugs we feel you should know. And she sits down, and she had Tagamet and Zantac on her worksheet. So I said, well, tell me what you know about them. You know, you tell me what you know, and I'll try to help. She goes, they're for allergies. Well, kinda. Actually, if you took a Tagamet, it actually does have some help if you're having allergic response. But I need you to keep these kind of separate, because Tagamet is for GERD, a disease called GERD, and that's what Zantac was being used for. Pepsid also. Kind of keep them different. I kind of feel like she hadn't really studied if she didn't realize these technically fall in the same class, but they're used for different things. So I want to make sure that you guys all understand that there is a difference. We'll tackle these drugs down here in the white box later on in the term. Let's talk about antitussives. Antitussives are cough medications traditionally sold over the counter. Robitussin DM is one. The DM stands for dextromethorphan. That is the name of Robitussin. But what exactly is an antitussive? It's a medication that will suppress coughing, and that is all that it does. It doesn't cure anything, doesn't dry it up, just stops the coughing so you can get some sleep. They believe that this drug works by inhibiting the coordinating region in your brainstem. They stop the cough reflex arc. They don't really know how it works. I can tell you I don't hesitate to give it to a patient if they haven't had any sleep. I found this interesting slide that I added a little bit later here this morning. It says antitussives, expectorants, and mucolytics. Well, we just talked a little bit about antitussives. If you look on here, it starts up in the upper airway where the little man has the spray can, and it says dextromethorphan. So it says non-opioid antitussive will reduce coughing. Watch out for drowsiness. If you go to your left, there's a little man down in the lung, and he's making mucus. And it says Mucinex. Guanifacin is Mucinex. It's an expectorant that decreases the stickiness of your respiratory secretions. It's that ad where you see that little green man, and he says, I'm going with you to work. And the lady says, no, I took my Mucinex. That's the same medication. If you go over on my right, you're going to see there's a little man in there, and he's doing something. You can't seem to tell what he's doing, but he says, this stuff is so thick. The bacteria and viruses are growing in it. Mucolytics break the links that bind the mucus together so it can be coughed up. And that's a drug called Mucomyst or acetylcysteine. Acetylcysteine is also the drug that you take if someone has a Tylenol overdose, interestingly enough. So these aren't huge in your textbooks. In any of the textbooks I went through, these weren't huge topics because most of these medications are sold over the counter. But it just kind of get an idea that they actually are three different things. And if you go and walk into Giant Eagle, or I was in Mark's this morning, some of these come in combination products, so you got to kind of make sure you know what the patient is taking. I did want to point out about codeine being a cough suppressant. It is a wonderful pain medication. It comes up under pain control. But it's also a wonderful antitussive. You have to have a prescription for it. You have to go behind the counter. I have to sign to get it from the pharmacist. I decided I could not find a picture that was worthy of putting this in here, and I'm not that great at these voiced over things yet anyway. So I put a drug card here from a drug card that was typed out from the drug cards from ATI. If you look on it, it says codeine. It's an antitussive and an opioid analgesic. It suppresses the cough through action on the central nervous system. And if you go down here, it has all central nervous system effects: dizziness, lightheadedness, respiratory depression. This is also a drug that has a notorious issue where it will cause constipation. It's also very addictive. So I just wanted to point that out. If someone requests codeine cough syrup, they keep it's considered to be it'll be kept. If you have codeine cough syrup, it'll be kept in your narcotics drawer. Here's Mr. Mucus. I know you're not here where I can ask any questions. I'm trying to improve the PowerPoints as I go along. Let me know if this is helpful to you. I may also go over it in class also, but that way this is available. And I hope you guys have a good day. It's Saturday here. The sun is out. It's very cold, but I hope you're all safe and having a great weekend.